Okay, so starting then with the introduction, you of course know the two of us very well, so I don't think we need to introduce ourselves. And I think the majority of the students in this unit actually has done one or other of our other units. And the best way, as usual, is to contact us by email, simply because I teach undergrad. I'm often in class, and Tony is a sessional. So it's best to send an email.
Imelda, just share your screen.
Oh, didn't I?
No.
Oh my goodness, I'm so keen to start. Sorry. It's this one. Yeah.
Yeah.
Okay, sorry about that. I'll just diminish that, and then we can go from here. That was just the invitation for the for tonight. Okay, Mel. So I think you might quite be used to the Moodle site by now. Knowing that under the unit information, you will find all of the information, and then also the assessments, and then under learning. So maybe I should, just for the sake of any student that might not have done any of our units, I'll just quickly go, and I think I've got that site open. Yeah, I'll just quickly share that site again and just quickly go over all of the tabs. Okay, so under unit information, you have the timetable. And if there's anything that changes in the timetable, I will update it, but I will also send a notification that there has been a change. With this unit, there very seldom is any changes. There's the assessment summary, which shows the information for the 3 assessments. And then just looking at the library reading list. So for 5109, there's essential reading. And the book that we have there is Otto Chan. And then the other books that's available, there's the accident and emergency book. We have got another book, Anatomy and Diagnostic Imaging, that's available online. There's an orthopedic book as well, which quite often is used for doctors, but some useful information. And then Jonathan McConnell, he was one of our ex-academics. So he's a co-author of the book Interpreting Trauma Radiographs. And then the other book that we really use quite a lot as well is Raby's book, Accident and Emergency Radiology. So all of these books you can see are available online. And what that means is that you don't need to go and purchase those books. You can download the books, and as you would probably have been used to, you are able to link the book. We link the book to the chapters that for our reading list, and then you are able to get access to the book just from your desktop. So I need to stop share, because what it does, if I do that, then it closes up my screen. So I'll just share again. Sorry. Okay. And then there's, of course, the image interpretation workbook that we also have available and that we've used quite a lot. Under learning, under getting started. So under getting started, you have got a summary of the assessments. So there's 3 assessments and their weightings, and we'll talk more about the assessments. And then the ISAP case. Now you will notice that under getting started, there's actually Dropbox as well for the ISAP case. In the Moodle book for the ISAP case is also a Dropbox. And the reason why I've put this under getting started is because when we mark the case, we actually mark the CAP and the CR report together. And we assign a mark, and that mark is actually uploaded against the CAP report. So the whole weighting sits against the CAP report, but it's the entire 2 reports that's marked. And because of that, and I'll show you the assessment tab. Because of that, under assessment, you will only see the CAP report, and that's why I upload this as well. And Your first assignment will be due on the 30th of August. So that is for the CAP report of the ISAP case. And then once the ISAP case has been submitted, the CAP, the expert report becomes available. So on the 31st of August, you'll get access to the expert report. And then a week later, the CR report is submitted on Friday the 6th. And then there's also the online exam. So all your assessments, and there's also the clinical portfolio and the Dropbox for the clinical portfolio. So all of your assessments and Dropboxes sit under getting started. If we look at the assessment tab, you can see it only shows the CAP report, but it shows the online exam and it also shows the clinical portfolio. So you can submit by going to the assessment tab. So for example, if you want to submit from there, they are all linked. So whether you upload via getting started or under assessment, it's the same thing basically, it's just transferred across. The other thing I wanted to just show is the support tab. So under support tab, and this is for all Monash University students, if you need advice on academic success, there is a link there. Learn HQ at the moment is very much involved with AI. So if you go there, you can read more around AI because the university takes generative AI very serious. And then also if someone struggles with English language, there's English support. And then student academic integrity. So when you submit assignments, it is about making sure that your work is your own, that it's authentic, and that there's no plagiarism involved. Then there's a link to extensions. So the short extensions, I'm sure many of you know, is you get an automatic 2-day extension if you apply for a short extension without having to provide any supporting documentation. However, if you need more than 2 days, then you have to apply for the formal special consideration. And for that, you will need supporting documentation. So in terms of the short extension, if you've noticed, for example, the ISAP case is normally the deadline for that is a Friday evening at 5 to 12 in the evening. You get 2 days. That means that it's extended until 5 to 12 on the Sunday evening. So every day is counted in the 2-day extension. And then there's an access to the library with, you can set up a meeting with the librarian. If you're struggling with something, there is a link to referencing and then also some other support. If you need to contact Monash Connect, there's a link there and any other student services is available here as well. If you struggle with your maybe with your device and you struggle to get onto Monash or onto the Moodle site, there's a direct link for students to eSolutions. So those are some of the main things that you can use under the support and also, of course, all of that access that we have. So if we look under learning, you will notice getting started is available and week 1. And then there is this, if you click on week 19, that's the same resources that I've shown you. And week 20 will actually be the forums that's sitting there. So when, as we release the material, more of the weeks will become available. So Mel, any questions around the site? I think you're quite used to it now, hey?
Yeah, that's pretty well standard now.
Yeah.
It took me a bit to navigate it initially, but yeah, that's made more sense now.
Okay.
The image interpretation manual, did you say that's been updated and changed since last semester?
No, it's still the same.
Still the same?
Yeah. So
Okay.
there's no change there. Okay, I'm just going to share my screen again and go back to the PowerPoint presentation. So as you are aware, this unit forms part of the grad cert in image interpretation, and which is mainly focusing on trauma, but also some of the common pathologies. And there's a link to the grad cert if you want to get back to that. And then for 5109, and there's a direct link as well to the handbook. So this unit is mainly concerned with the pelvis and lower limbs and the thoracic and the lumbar spine, and we will be looking at adult and pediatric patients. And as with 5108, we will be applying clinical decision rules as well. And then of course, quite important is to compose description. So this descriptive terminology in describing in your clinical portfolio, the cases, and also in the exam, your descriptive terminology. And of course, quite important is the interprofessional communication. How do you communicate and what can you communicate when you interact with other professionals? So the resources are pretty standard as for our previous units. So there's a weekly timetable, and as mentioned, the material is only released on a week-by-week basis. We try to release it on a Friday. If we don't get it all done, at least by the Monday morning early, it will be released. And the reason for that is so that you can scaffold your learning. We release it the weekend so that we see that many students actually work over the weekend, and then so that it's at least available for them. The Moodle books you would have been quite used to now has got a PowerPoint recorded presentations, but then also direct links to supporting references as well as similar like the ebooks here. So what we have built into, and that actually came about from last semester under 4502, is to have a catch-up tutorial. So we're only going to have one for this unit. So on the 18th of September, there'll be a catch-up tutorial. For that tutorial, students can send before the time if they've got any questions. And also I'll talk about upcoming assessments at the time. Myself and Tony will be there. So make a date then again via Zoom. On the 18th of September, we will have a catch-up tutorial for this unit.
Lovely. I found that one very handy last semester.
Yeah. Yeah, we thought actually because we only did it for 4502, with the other units, because students are now used to it, we thought at least just one. And we'll see if we might have to increase it for next year. So it's timetable there. And then the image manipulation software you would have been used to by now. We use it in the ISAP case. There will be formative tests. So for this unit, there'll be 2 formative tests to prepare you for the final exam. And we use the software in both the formative and summative exams. And then there's also a video to demonstrate the software, but I'm quite sure you're used to that now. And then for the exam, to access the software, there's specific login details with the username and password. So Tony, you quickly want to run through the online resources?
Just take the mute off. Yeah, I think, Mel, you probably wouldn't have come across this. I'm not sure whether any of the other students in this unit will have last semester, because I seem to have lost contact with Collective Minds Radiology, partly because my email address changed and what have you. But I'm going to re-establish contact with Collective Minds Radiology and make available to you links to appropriate cases, because this stuff, Collective Minds, is very case-based, and the cases are cases that people have found challenging or have good learning points in them, and people can post them, and indeed anybody who's actually enrolled or signed up, which is a free thing to do, free access, can actually post a case, and people from all over the world post cases. So they're mostly radiologists and radiographers who actually post the cases. and anybody who is actually signed up in Collective Minds can actually contribute, and they can actually input their opinion into what is abnormal about the particular case, and that is actually quite a useful learning exercise, I think, for all of us, and for radiologists and radiographers included. There's a good opportunity to actually learn about these cases. So I'll, as the semester wears on, I'll post cases for you to actually have a look at. The other website down the bottom of the slide there is actually a website that was produced by Ian Cowan, who's a radiologist from Christchurch. Ian, like me, has actually retired now, but he actually created this great little website which is actually directed at radiographers, particularly radiographers in developing countries where there's usually no radiologist available, and so it's actually quite well targeted to learning, I guess I could say, the basics, but I think in some cases more challenging aspects of image interpretation as well. So it's a good little website. It's free to access again, and it's something that I've referred to in various presentations in this unit and in the course generally, and acknowledge Ian's expertise, and some of the material that's actually included in my lectures is actually stuff that Ian and I worked on together. We worked together teaching image interpretation in Pacific Island countries for a few years, and yeah, I've made use of some of that and built on it, of course, and enhanced it. But yeah, so if you actually go and have a look at that website, it's actually quite useful to do. Any questions about that, Mel, at all?
No, there was I think it was that one from last semester that I found quite interesting.
Yeah, so that's good. Okay, I'll mute again,
Okay,
Imelda.
thanks, Tony. So 3 assessments then for this unit. There'll be an ISAP case, so you are now used to an ISAP case. There's the online exam and the clinical portfolio. Now, the competency hurdles are only applied to the online exam and the clinical portfolio. And although the ISAP case doesn't have a competency hurdle, it's got quite a big weighting, so it's a 30% weighting. So I would still encourage you to do your best with the ISAP case because it contributes to your total unit mark in the end. And then I've given here the dates. So the ISAP case will be the first one that you're going to do. So the 30th of August is the CAP, and then the 6th of September is the CR report. The online exam takes place during the formal exam period for the university, and this will be on the Thursday, the 31st of October, and the duration is 100 minutes, and it covers all of the materials that you learn here, so all of those weeks. And that's why we have 2 formative tests, so that we break it up into 2 parts, so that you study some of the material so long, and then the last bit falls into week 12, so that you can have a good idea of what can be expected. What I would really encourage any students, not just Mel, but others listening, is to make sure that you either have a day off on that exam or half a day at least. It's a long exam, and you need time to prepare yourself mentally for the exam as well. And then the clinical portfolio, the deadline for that is the 13th of November, and all of the resources for the clinical portfolio will be found under this week starting 22nd of July. Then just a bit about academic integrity. The university takes it, of course, very serious. Now, I think you would have probably have completed a compulsory module already. So if you've done that in semester 1, you don't have to do it again. You will get a notification if you haven't done it or if you need to do it. And I would like to encourage you, if you do get that email, is to complete the module. Because if you don't, you might find yourself completely locked out of Moodle, and then you have to try and get back. First complete the module before you actually will be allowed to get back onto the Moodle site. So please, if you, any of the students here, if you haven't done the compulsory module, please do it as soon as possible. As I mentioned, AI is a big deal. It's a big deal in your university as well. And as I said, under the support tab on the Moodle side, there's a Learn HQ site, and that has got a lot of information around the use of AI. So you can have a look there at what's expected, how do you cite AI sources, and so forth. But having said all of that, for this unit, we expect you to demonstrate your knowledge, not a computer-generated knowledge, and also the skills that you acquire through the course without the assistance of AI. So therefore, AI is not allowed in any of the assessment tasks. I've already talked about the SpecCon, so I'm not going to dwell longer on that, but the team that handles the special consideration, they are the SpecCon team. For short extensions, they approve it. I don't approve it. For the longer special consideration, they might come back and to me and say, listen, this is the student has applied for so many days or so. Do you agree, or whatever the case may be? So short extensions is not approved by me, it's approved by the SpecCon team. Okay, now let's look at task 1. So you've got the ISAP case. And for this semester, the ISAP case is concerned with an ankle. And then it has the 2 parts, the clinical action plan and the comparative report. The clinical action plan is the biggest part of the ISAP case. It's 1,500 words, and the comparative report is only 500 words. And there's a 10% leeway on both. It means you can have 10% less than 1,500 or 10% more than 1,500, but stay within that leeway of the word count. The overall weighting, as already mentioned, is 30%. And as postgrad students, you are only allowed 1 submission. It means that when you submit your CAP report to the Dropbox, you can't decide, okay, I now still want to make some changes and resubmit. It will be a final submission. And an integrated Turnitin report will be generated immediately. And most of you probably know by now that Turnitin is a software matching program where it tries to detect if there's any evidence of plagiarism. Now, the faculty has a cap of 15% on similarity index. If your similarity index comes back, because you also get the report and it's more than 15, don't go into panic stations, because quite often the students would include the questions again, and that's matched 100% that those questions, and it also adds to the similarity index. So normally the marker myself, if Tony doesn't, I always go in and check the Turnitin reports and the similarity index and see if there is any evidence of plagiarism.
How does that go with things like if you use the same terminology to describe something that you've seen in the X-ray in your interpretation, if you use the same terminology as the expert report, for instance, in the CR, wouldn't that come back as a
match,
plagiarized
no
match, because it's the same words you're using?
Yeah, one thing that you often find, and you find it especially in a course like image interpretation, there's terminologies that are very common and that students will use. So what I do is I set that it only picks up the first 8 words is not picked up as plagiarism. So if it's longer than 8 words, then it will pick up and it will then identify if there's plagiarism. Normally, when you write something, it's very seldom that you will have 10 words following each other that's exactly the same.
No,
so I
no,
set a
no.
limit of 8 words, so that after 8 words only, it then starts to look at and see if there's plagiarism. So don't worry about that, but because
Okay.
there's a lot of the similar terminology that you will be
Yes.
using.
And if we're aiming to describe things radiologically correct, then they are going to be
Yeah,
the
there
same
will be overlap, and
So,
that's why I've got
yeah.
that 8-word limit, exclusion
Lovely.
limit.
Thank you.
Okay. And then, of course, as you are aware, once you submit your CAP report, and only if you've submitted your CAP report, and only if the deadline has been reached, then only will the expert report become available. So if you submit your CAP report a couple of days before the time, you won't get it until when we look at the date, the 30th of August. So basically the 31st of August is the first time that the expert report will become available. And then you need to compare and contrast, of course, the CR report, and then that's submitted on the 6th of September. And as mentioned, all the resources will be available under week 1, and there is an ISAP Moodle book with the ISAP case. Sorry, under week 2. I'm in last night's mode. Under week 2, because next week we will be releasing the ISAP case. I've already mentioned about AI. Okay, so with the online exam, so that has got the biggest weighting. So it's a 40% weighting. And then all of the teaching material, and as you are aware, majority is presented as Moodle books. So go back to the Moodle books and go over the resources that we've given, the PowerPoint presentations and so forth. You've got the image interpretation manual, and then the weeks where the material has been covered. So it's quite a lot of weeks. And that's why we've got 2 formative tests. So one test is in week 9, and then the next test is in week 12. And those formative tests, and I really want to encourage students to undertake the formative test because it really mirrors the types of questions that's going to be asked in the exam. It also makes use of the image manipulation software as well. And then what I normally do is towards the end of that week, when I've given the formative test, I provide video recorded feedback on each of the formative tests. So during the formal exam, you will have the computer-based exam, which is undertaken from the Moodle site, but you will also have access to the image manipulation software. And for this unit, the exam will take place on the 31st of October. It's a 100-minute exam, including reading time, and you can undertake the exam anytime from 8 a.m. in the morning until 8 p.m. in the evening. If you start very late, make sure that you will have enough time to finish the exam before 8, because the exam shuts down automatically at 8 p.m. What I normally ask for is for students to email me the suggested start time. And I use the word suggested. It doesn't mean if you say 10 o'clock, it has to be 10 o'clock. It's just that I need to make sure that I'm available if you need any support during that time. Because the exam runs until 8 in the evening, I'm the only one that actually monitors the exam, because the university they don't provide any support. I think the latest that they do is 6 o'clock. So they won't take on an exam that finishes after 6 p.m. And then, yeah, so the exams are password protected. So your Moodle exam, you require password. The image manipulation software, you require password and login details. And I only provide that about half an hour before the exam starts to each of the students. The clinical portfolio, the due date for that is in the last week of the exam period, and it's on the 13th of November with the overall weighting of 30%. And as mentioned, you'll find all the information under this week. So a minimum of 25 clinical cases, which is concerned with the body regions that we've mentioned, the pelvis, lower limbs, thoracic, and lumbar spine. And each of the cases, on average, about 80 words. But if it's more or less, don't worry. Normally, the overall word count is about 2,000. And then each case is worth four marks, with your overall marks for your case reports will be 100 marks. But what's also really important is to include normal cases as well. Students tend to think they only want to demonstrate the fact that they can identify pathology, but it's even more important to make sure that you don't identify pathology when it's not there. So identifying normality can even be more difficult than the abnormal cases. So you must include both normal and abnormal cases. Now, you could use references when you pick up something, you know, that's very new to you sometimes, and you want to go read more about that. That's encouraged, but it's not essential. So that is the one is the clinical cases that you write up. And the next one is the self-auditing PI record. And the overall mark for that is 20 marks. So included in the 20 marks is that table that you have, that you list all your cases and where you write up whether it's true negative or true positive and so forth. And then the calculations as well. So where you work out your sensitivity, your specificity, and your accuracy. And that together makes up 15%. And then reflection on your ability to interpret images, that will be 5 marks. So those two, the two together makes up 20 marks. Quite important is that every case needs to have a number. So start off by numbering your cases. Students tend to forget it. So start off with case 1, case 2. It doesn't matter that they are mixed. You could have a pelvis followed by a thoracic spine, followed by an ankle. Or if you want to, you can keep them together, but it really doesn't matter as long as you list them chronologically in order. And then when you compare your preliminary evaluation to that of the radiologist, remember it's only related to the clinical question. Quite often, the patient might be referred having had trauma. The radiologist will include further information around maybe degenerative stuff that they see. Say if it's a knee, they might say, oh, there's some arthritic changes to the knee. That's not important. The main question there was whether there was a fracture or any other related injury. And that is where your PIE should be concerned. However, if you do pick up something that's not the clinical question, but it's quite significant. So say, for example, take an X-ray of your knee and you see, but something else is happening in the bone. It could be that there's a metastasis, or there could be, say, for example, an aneurysmal bone cyst. You need to mention that as well. It's only the degenerative things that you do not need to be concerned about. And at the bottom of each of the cases, please indicate how you have assigned your true negative, true positive, false negative, and false positive as well. So I think the next slide shows now about the self-auditing PIE record. I've mentioned you must consider the clinical question when you fill that in, and then have normal and abnormal cases. I think the majority of this I've already mentioned. So sometimes you need to use fractions. For example, if there's 2 pathologies, say there's 2 fractures, you've only identified one and the radiologist actually picks up another one, then you can only assign half true positive because you've only identified half of the abnormality. And then the other half will be a false negative. But remember, each case must be equal to 1, not equal to 2 or equal to 3 because you've seen 3 pathologies. Each case must be equal to 1, and that's the reason why you're using fractions. And then, of course, also your calculations as well. Now, here's an example of how you should write up a case. So this would now be your case number 10. It's an ankle, the clinical indications written there, and then also include at least 1 image. So the preliminary image evaluation by the student was that there's a Salter-Harris type 4 fracture of the left medial malleolus. There's an anterior teardrop sign indicating joint effusion and significant soft tissue swelling. So the student said the report is consistent with the radiologist's report, however, indicated that the medial malleolus fracture was a Salter-Harris type 4, whereas the radiologist's report actually stated that it is a type 3. So overall, about 2/3 of that report was correct, apart from the fact that the Salter-Harris fracture was a type was incorrect. Now, I've assigned here 0.67 for true positive and 0.33 for the incorrect identification of Salter-Harris. However, in these cases, use your own common sense when you assign that. You might have maybe a true positive, true negative, and a false positive as well. So look at the case, look at how many pathologies there are, and then assign what you think it should be. So use your common sense when it gets to that. So then, just in conclusion with the introduction to the unit, remember material is released on a week-by-week basis. Make sure that you stay on task. So make sure that you go over your material regularly. And then also ensure that you start with your assessments early on. With your clinical portfolio, you can start collecting your cases quite early on so that you don't have to panic at the end. You know, I've now got to write all of this up as well. So as always with myself and Tony, if you've got any questions about anything, please feel free to contact us.
I know this is going to sound like probably a silly question. I was reading through when you were saying about thoracic and lumbar spines.
Yeah.
Because we're going to be discussing 5114 tomorrow night, and it's chest and abdo, is the thoracic and lumbar spine PA views, whereas the chest and abdo are AP views? Is that
a chest is
difference between them?
Yeah, so your chest, the standard view for a chest is normally a PA erect. But if your patient is in ICU, so it means if you think about it, the patient stands with the back to the radiographer. That's PA,
Yes.
and the
Yes.
chest is against the cassette.
Yes.
And if the patient, say, for example, is in intensive care, you will have the tube coming from the front, and that will be AP. So it depends on what the patient can do, what position you're going to use. But the standard position is PA with the back to the radiographer. And the reason for that is the heart is then closest to the cassette so that you don't have magnification of the heart. And that's why a PA is preferred. However, it can be AP because a patient in an ICU can't turn on to lie on their stomach. Yeah. So it can be anyway.
But then the clinical portfolio for tomorrow night, what's the views that I'd be looking for?
Whatever case you get.
If the chest is PA and 5109 is thoracic spine, would that be the AP views?
Yeah. So don't tie yourself into knots, Mel. The spine, normally when we x-ray the spine, remember the spine is at the back.
Yeah.
Okay. So you want the spine closest to your cassette or your receiver. Okay.
Yep.
So your x-ray tube will come from the front, so it will be AP. That
Yep.
would be a normal, and you would turn the patient on the side and you will do a lateral.
Yes.
So the normal position for spine is AP. If you think about the abdomen that we're only also going to do tomorrow, will also be AP. Okay, that would be the standard. It's for the chest, which can be AP or PA, but as I said, the standard position would be a PA, and it will be erect. Does that make sense?
Yes, thank you.
Okay. Do you have any other questions around the introduction that I've done, because I just want to quickly, just a short intro about the portfolio. So if you don't have any questions about that, I'm just quickly going to run through that one as well. You can see that?
Yep.
What does it tell me? Please move this window away from, I don't know what. Sometimes the screen does very strange things. Okay. I don't know why this thing is coming up. Sorry, I just want to just go back. Please move this window away from the shade, but I can't move it. I've never seen this coming up. Anyway, so I'm just going to give a brief intro about the portfolio, and I'm going to start just at the main slides here because I'm just conscious of time. So the Moodle book for the clinical portfolio is available under this week. And then information that you might need to complete your portfolio will sit in some of the other Moodle books as well. I'm going to post this recording on the Moodle site, but I think what I'll also do is to do a narration of this presentation of the introduction, just so that it is separate from tonight's session as well. So I will do that probably only tomorrow. So I've already discussed quite a bit of the clinical portfolio in the intro. So the weighting is 30%, minimum of 25 cases. You can add more. Some students would do 28. They might say, oh man, I've come to 20 or 22 and I've only had 2 normal cases. I need to add more. So some of them might add a little bit more. It doesn't matter as long as you then mark your total adds up to the number that you have, but you must have at least 25. And then there's also then the separate PIE record, and both are uploaded to the same Dropbox. So the submission deadline for that is on the 13th of November. So with the clinical cases then, 25 cases, each one is marked out of 4. And the total mark for the clinical case reports is 100. And as mentioned, around 80 words per case. And then also ensure that you include the correct body regions. So pelvis, lower limbs, thoracic, and lumbar spine. And something that I might maybe mention, so say, for example, you have a patient where the patient has been referred, say, for a lumbar spine, but then the patient also had a pelvis, and you want to write both of that up. Write them up as 2 separate cases because it's very difficult for you to actually assign what you do. And I've seen students struggle when they have 2 different body regions trying to do it in the same case. They get tripped up amongst that because the pelvis might be normal and then the lumbar spine might be abnormal, and now they don't know how to assign, because if you write it up as 1 case, it will still be equal to 1 mark. So if you've got 2 body parts that's been x-rayed at the same time, I would suggest just write them up as 2 separate cases. And then, as mentioned already, you have to include normal cases as well and abnormal, and make sure that you have got a range, a variety of cases that covers the body regions. And also AI is not allowed. I don't think you can actually use AI even if you want to in cases like these. So what you need to include in your case is the clinical indications, for example, the mechanism of injury, your de-identified images, and then write up your preliminary report and then compare that to the radiologist reports. Now, you can include the immediate management of the patient. You don't have to. That's additional. And then you can include references, but it's not essential. Only include them if you find a case that you really found interesting and that you actually want to reference. So you can include references as well. So in your case report, so this is just a summary. So the presenting symptoms, you are encouraged to use the ABC search strategy while you are scrutinizing your images. However, when you write your PIE up, you don't have to go through the whole of the ABC. Otherwise, your word count will become too long. So what you need to do is to focus. So if it's an abnormal case and you identify that there is a fracture that involves the joint, then you would write about the bones and the cartilage. But there's no alignment issues. So you don't have to include all of the ABC points when you write up your PI report, just to save some of the word count. And as mentioned, de-identified images. And I've already said that when you compare your report to that of the radiologist, focus on the clinical indications.
Do you need to include all the radiologist's report? I found with the clinical portfolio last semester, a lot of the word count was
The
quite
radiologist.
extensive radiologist's notes.
Yeah, so you can write it up. So if you look at the screen now, so what the student said, the radiologist's report matches the majority of that was written in the preliminary image evaluation, but only mention the areas that did not match. So you can also do that. So when you answer the clinical question, yes, trauma related, you are dealing with a fracture, there's some soft tissue issues there. So if that matches, that's all you need to do. You can say that the radiology, you don't have to copy, cut and paste the whole of the radiologist's report. Okay. And then at the end of your case, please write down your whether the true positive, you have got false positive and so forth. Please add it at each case. And then with the self-auditing PIE record, as I already mentioned, that's marked out of 20. Make sure that in your table you cover all of the body regions. However, if you work at a site where you don't really see some of those areas, you can actually, if you've got satellite sites that you work with, remember the cases that you include. As a nurse practitioner, for example, you're not going to x-ray that patient. You can use cases on the PAC system. But if you find that you are not able to get, say, for example, thoracic cases, just contact us and let us know that you've never seen one, it's never been x-rayed here. And we have had those exclusions for some of the students where they work in a specific area and they can't get all of the body regions. But we need to know that beforehand to approve that exclusion. And then, as mentioned, make sure that you have normal and abnormal cases. Now, normally the abnormal cases will be more than the normal, but you should at least have about, say, 5 to 8 normal cases as well, so that you can at least have a decent number of cases to work out your specificity. And then you assign all your either true positive and so forth. And then just as an example again here, sometimes you have to use fractions. So if there's 2 fractures, you've only identified 1. And then the radiologist mentioned something else, then it's only half of a true positive and half of a false negative. So important is each case can only be equal to 1. You can't decide, I'm going to make it equal to 2, because then in the end, it does not work out at all. So each case must be assigned in such a way that it's only equal to 1. So with that table that you have with your 25 cases and how you've assigned it, as well as the calculations here, all of that is equal to 15 marks. And I've given you the formula to work that out. And then 5 marks will go towards reflection. So the reflection is not just about stuff that you still think I'm not good at, that I'm struggling with. Remember, you've learned quite a lot. So just write briefly the areas that you really feel good about yourself, where you feel that you've made quite a remarkable improvement on. So it's not just the negative stuff or the things that you think needs to be improved, but the ones that you have achieved through this unit as well. And then this is just a summary of that. So in the table then, where you have all your body regions, you will need to add more lines, rows to that, sorry. So when you add this up, and if you have 25 cases, it should add to 25. But if you add up all of your true positive, all of your true negative, false positive, and false negative, if you add all of that up, it should be equal to 25 as well. Because remember, each case is only equal to 1. So you can't have more in this row than what you actually have in terms of cases. And I think that's where some of the students just really struggle with assigning their true positive and true negative and so forth. And this is basically the 2x2 decision-making table. It's a very simple one. And that's where you look at the radiologist report, which we use as the gold standard. Now, I'm saying gold standard because I've had students, and these are now mostly radiographers, of course, who has written their PIE, and then they compared to the radiologist report. They've identified something which the radiologist did not identify. And the student, and it's come through a number of times already, where the student actually was so certain something was wrong, so that the radiologist actually missed something, and that the student then went to the radiologist and asked the radiologist to review the case and maybe showed what they thought. And at times it happened that the radiologist changed their report. It also happened that the radiologist said, no, it's normal. And then the student felt so strongly about it, went to the referring physician and said, I'm quite sure there's a fracture here. The radiologist says there isn't, and actually encouraged the referring doctor to send the patient for a CT scan, which showed the fracture. Okay, so if there's a review where initially it looks like you have identified something that the radiologist didn't identify, but then when you include more information which shows that what you've written in your PIE and the final report actually matches yours, then yours is a true positive. Now, sensitivity is concerned with picking up the abnormals. So you want to have that as high as possible so that you don't miss out on pathology. So you should aim at having a very few false negatives. Specificity is concerned with the normals. Again, you want to have as few as possible false positives. And the reason for that is, say if you work in a rural or remote site where the radiologist is not around, you become the expert maybe for the doctors or the nurse practitioner that referred the patient. And you might say there is something there that's not there. So you incorrectly identify a fracture that's not there or something that's not there. It could result in unnecessary treatment. It could result that the patient is referred for additional imaging, additional radiation for the patient, which is unnecessary. So you want to keep your false positives as low as possible. And then accuracy is just the overall image interpretation accuracy, your combined abnormal and normal cases to see what your overall accuracy rate is. So as mentioned, you can start collecting your clinical cases, and Tony will probably give you a bit more advice about how to collect those clinical cases. Make sure that you have normal as well as abnormal cases. And if you are concerned with any of the cases, I've had students who actually sent cases and said, I don't know how to assign this. Can you help me? So if you are unsure, please feel free to contact us, and we can assist with cases. Tony, is there anything you want to add there?
Yeah, thanks, Imelda. Mel, how did you go with collecting cases in the upper limb and cervical spine stuff? Did you find that you had reasonable access to images?
Yes, I did. However, your comments about trauma was, we see a lot of mums that bring kids through that say they fell at football on the weekend and they just won't stop complaining about it. So snuff box, let's get, yeah. So, or they've just fallen over for, because we apply back slabs and I do up the imaging request and then refer on to fracture clinic as required. So upper limbs was actually quite good. The majority of the cervical spine was degenerative changes. older gentleman's walked in and gone, I just can't get this crick out of my neck. It's been there for months and I don't know what else to do. And they're more degenerative changes rather than high-speed
Trauma.
MVSAPs.
Yeah. Just a little bit of general advice about sort of collecting cases, because the temptation is to actually, as Imelda said, to sort of collect the positive cases that you see go past your eyes, and to forget that you actually need, a mix of a cross section of cases, that sort of is broadly representative of real clinical situations, which will of course include normals as well as abnormal. So try not to be, introduce a bias by just collecting the cases that you feel most confident with, or, and ignoring those cases that you feel you may not be competent in interpreting, which is always a little bit of a risk with this, and try to actually include, sort of broad cross section by, I suggest sort of allocating maybe a particular day where on that day you're going to actually use all the cases of lower limb imaging that come past your eyes, whether they be normal or abnormal or somewhere in between. And so that way you're not sort of biasing your study, your collection of the measurement of accuracy. So if you sort of allocate some periods, and they might, I'm saying a day, but it could be a week, it could be 2 weeks, where you're actually collecting data for your clinical portfolio. So that would be good, just to keep that in mind. And as Imelda said, please feel free to contact either Imelda or myself if you're actually having difficulty or you don't understand something. The other thing that I'm just going to mention while I've got the floor, Imelda, if that's all right, is I believe, Mel, you found like that glossary of terms actually quite useful to help with the
very
lingo,
much so.
with the language thing. And I think that may be true of other students as well. Maybe other nurse practitioner students or other physio students, or maybe paramedics, or what have you. And those glossaries of terms, and there were actually 2 glossaries of terms there. One was sort of technical stuff and one was sort of more radiographic and anatomy type stuff. I think that they were made available under 4502 or RAD 4502, but not under these
units. Maybe we should actually
course.
maybe we should actually include it in these units as well.
Yeah, I think we should, Imelda, just make sure that they're included in both units. And I think the other thing that comes to mind, Mel, and other students, is in 4502, there was a presentation, which was a scroll through presentation on radiographic evaluation criteria, which showed the standard views for all examination types that are actually included in this grad cert. And that's important to understand. And I think it helps in some ways answer the question that you asked, Mel, about whether the patient's back or whether their front is actually, again, for particular examination types. That presentation, that scroll through presentation of radiographic evaluation criteria, shows AP thoracic and lumbar spine, lateral thoracic and lumbar spine, PA chest and lateral chest, and it distinguishes between what you can actually see on those examination types. So I think what I might do is actually just create a little folder on.
Maybe we can put it under maybe getting started or under resources, we
Yeah.
put it under resources and just say this is available. It's from 4502. This is a copy if you want to go to that. Yeah, maybe
that would be helpful, because I went through 4502 and out some of the ones that would be cross useful.
Yeah.
Even if it's just the reminder things, systematic interpretation, etc. And I'm just having a quick look through. I don't think it's one that I've. Oh no, hang on. Radiographic evaluation criteria. This could be the one I'm referring to.
Yeah.
Yep, routine projections, lumbar spine, thoracic spine. Yeah.
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 It's
So
got
that
all the routine projections are there.
Yep.
Like for chest, it doesn't show both PA and AP. AP being an alternative to the PA, rather than a routine view, I guess. And it doesn't show all the additional projections that we actually do, that might show particular anatomy or pathology.
So Tony, maybe what you should do with that one is to maybe just include the slides as applicable to, say, 5108, the slides as applicable to 5109, and the slides that will be applicable to 5114. And we can either add it, under getting started, or as I said, we can put it under the resources tab.
Yeah, that might be a good idea.
Yeah.
So I can do a little bit of an edit on that and make it available for.
And then also that
week
glossary
2.
of terms again, if we could put that there, that I think would be useful. Would you be okay to do that?
Yeah, I can do that and make it available for week 2.
Okay, awesome.
Send out message to students, and do the same for
5114 and 5108 as well. Yeah.
So hopefully I'll get that done for between now and the end of the week, but we'll see how we go.
Okay, thanks, Tony. Mel, do you have any questions for us before we actually say goodbye to you?
No, I really just wanted to try to get that straight in my head about the difference between the chest and the thoracic, because obviously they're going to go in 2 different portfolios. And thank you. This is what I was trying to remember.
Yeah. But I can see you very diligent, because you've got everything at hand printed out. Your references are there.
Yes.
And that says a lot, Mel. So really appreciate that. And one thing I must say, you always attend these sessions, these intro sessions, which we really appreciate as well. So we will probably see you tomorrow night as well, if you're not working.
Yeah, no, I will be on. If I'm not here, it's because something aberrant has occurred. I have every intention of being here tomorrow night as well.
So Mel, just to remind me, you're at Bree, are you?
No, Collarenabri.
Collarenabri. I knew it was out that way. So So Collie, there's a radiographer there, isn't there?
There is a visiting radiographer based from Walgett. He comes over once a fortnight, I think.
Oh, Frank.
Yes.
I know Frank. Say good day to him.
So
okay, I'm going to stop the recording now for now, because we don't.
We're just chatting now.